Good afternoon, ladies and gentlemen. Welcome to the 9th in our RSM Live series. Now, first of all, you may be noticing I'm looking a little different to what I have done in the last members of this series. My laptop finally melted about 2 hours ago and is now a twisted heap of scrap metal on the floor, so I've switched to iPhone. But some things don't change. It's the quality of our guests. Now, we're doing something different today. We've had so many questions asked over the course of this series that we were not able to answer, a total, I think, of over 800, that we decided we'd have a kind of, as this is the end of the month, we'd have a kind of wrap-up session and try and work through some of the questions that have been asked repeatedly, and we're feeling a little bad that we really should have got to. So to do that, we brought together a panel to address these issues. So let me just introduce the panel to you. We have two newcomers to this series. First of all, Dr. Sarah Filson is with us, an infectious disease and microbiology registrar doctor in Norfolk Park and St. Mark's, also one of the trustees of the RSM, also a major player in TED ex Houston, in doing work with Africa and the African diaspora. And Sarah, I believe you actually were a journalist before you decided to study medicine. So you've clearly gone from the ridiculous to the sublime. Then Dr. Ebere Okereke, welcome. You are a consultant in global public health and leader for Public Health England's Strengthening Project, IHR Strengthening Project. You've got over nearly 30 years experience in practice in many, many countries, all connected with infectious disease prevention and control. You're currently leading the development and implementation of the PHE program, strengthening capacity in middle and low income countries, an area that we have not really talked about and now are going to do that. And back by popular demand, Peter Openshaw, still the Professor of Experimental Medicine at the Imperial College London, still a major expert on the immunology of lung and viral lung disease, and has been rarely off our screens since the crisis began. Indeed, you may, I know, have to leave us slightly early, I assume, to go back and do yet more promoting of your very latest paper that came out this morning. And hopefully, Professor Hugh Montgomery, Hugh's the chair of intensive care medicine at UCL, gave a wonderful seminar for us a couple of weeks ago, directs the ICU at the Whittington, an incredibly busy man with no fewer than 300 publications, major campaign on climate change, also has conducted research on Everest, run 3 ultramarathons, but in one of those things that must have seemed like a good idea at the time, but haunts you forevermore, holds a world record for playing the piano underwater. So, I don't know if Hugh is here yet or not. I can't see anyone yet on the screen, but we hope he is. So what we're going to do then, I'm going to work through some questions, try and keep them thematic, but come up to and involve the panel as we go along. So I'll start with a named member of the panel to help the people running the webinar. And so Peter, let's start with you with a question that I never got to put to you 2 weeks ago. I mean, it has come from a lot of people. And this is, a lot of people are confused about just how this virus spreads. Is it small droplets? Is it large droplets? Is it fomites? Is it this? Is it that? And what are the implications of these? And I'll bring the others in on preventative measures, including, of course, the value of face masks, 2 meters and so on. So what do you understand now about the spread of the virus?
I think it's an extraordinarily important question, and one that actually we have very little knowledge of. So I'm glad that so many people have brought this up. I mean, I think the assumption from the beginning was that it spreads much in the same way as influenza. And a lot of the advice that we are giving is rather dependent on that assumption. And I don't know that that's exactly true. There's a paper out recently which shows that the virus is abundant in the saliva of people with infection, with COVID infection. If that's the case, then I think that's a bit different. I mean, although it is present in the saliva of some patients with influenza, it's not really super abundant. So, and I think that's in contrast with SARS, COVID-1, because that also is mainly a lower respiratory tract infection. And maybe that was why it was easier to get that one under control. If it is saliva, and if transmission is going on from salivary droplets, then that's important, but we don't know that yet.
Okay. Anyone else want to come in on that and tell us a bit more about what we do know? Or Ebere, how does this affect the kind of thinking of PHE on this issue and the changing views?
I like a phrase that David Heyman used in one of his numerous interviews recently, which is that we're all building the ship while we're sailing it. So we have to start somewhere with what we think is happening, develop guidance, work alongside it, and evolve and be ready to adapt and explain why we're changing things as we learn more. So currently, most of the guidance that's developed around infection prevention and control is on the assumption that the major means of transmission is droplet, with environmental mite contamination as a consequence of that. So that is the foundation for the distancing, the hand hygiene, the environmental cleaning guidance that we're giving. So, I mean, if new information becomes clearer about what the role of transmission from saliva, for example, or any other means, then we have to ask ourselves the questions whether the current guidance we're giving is appropriate, needs to be modified, and how will that change. But I think the most of the guidance at the moment would capture and provide protection even if there was additional evidence of transmission from saliva. There's also been mentioned, and I'm sure Peter would have heard about some of virus being found in feces and other fluids. So we have to ask ourselves the question, do the infection prevention guidance we're giving now, would that work for that? And if you're hand washing and cleaning your environment, then in principle, yes, that should work. But we won't know until we learn more.
Sarah? Anything to add? You still there, Sarah? Joys of webinars, what fun. Well, whilst we try and find where Sarah's slipped off to, leading directly on for that was one of the very popular speakers we had was Trish Greenall, who was there to talk about face masks. And anyone who listened to that would be in no doubt that Trish, and anyone who's followed any of the media since, that Trish is strongly in favour of this, although she stopped short of saying this should be made compulsory, but she certainly did think the advice should change and people should be encouraged to wear face masks when outside the home. I just wondered, Ebere, whilst you're still on the screen, again, massive issue for you and for Public Health England. Where do you stand now on the issue of face masks?
Simon, I assume that for this purpose, we're talking about face masks outside health and social care settings.
Yes, sorry, yes, absolutely.
Yes, because I think the evidence is very clear about the purpose in health and social care settings. So it's about the members of the public, whether they're well or not, wearing face coverings of some sort. The jury's still out. The WHO has produced some guidance that sort of defines the conditions and the criteria for considering face coverings. The biggest concern is that does it give people a false sense of security that they stop doing the other things that we think are effective? I don't know. The one thing I'm sure about is that we don't know enough about the use of non-pharmaceutical interventions, including face masks, outside hospital settings. We don't study it. Most of what we know about face coverings of any sort is very specific to high-risk settings such as intensive care units. We don't even have that much research into using them in care homes, and definitely not outside the hospital setting at all. There's very little evidence. The few studies that are out there are small, of questionable methodology, and the conclusions are very limited. So with the absence of knowledge, what do? We definitely don't mandate it, in my view. I don't think we can make it mandatory that people must wear social masks, face coverings in certain circumstances. People are voting with their own, pockets and buying or making all sorts of face coverings and making their own decisions. I don't know is the short answer. I don't want to come off the fence on this one.
Well, that's fair enough. I mean, I do remember Trish saying that some of the arguments against, like it would stop people doing other, that they would get lax in other issues. She did challenge myself and the audience to produce any evidence for that, and it was difficult to find evidence for that kind of counter argument as well, which was a fair point to make. Peter, What do you have to say? We didn't cover that when we were talking to you, but you must have a view, I would have thought, on face masks for the general public.
Well, I think we need more research. But I mean, it's perfectly possible to try to quantify the amount of virus that is emitted as splutter while you're in conversation. I've noticed when talking at a party to some people, if you're close up, you can sometimes feel a bit of splutter on your face or in your eye. And we know that there are receptors for COVID in the cornea. I think it's an important question I'd like to know the answer to, is whether not face masks, but informal face coverings do prevent that sort of splutter. There's a very nice video online to accompany a letter in the New England Journal where they were using some laser interferometry, I think, to demonstrate the splutter that you get during normal speech, and to prevent that using the facial covering. I think there's an argument for doing that research. Yeah.
It certainly did look very visually gripping. As people now know, as everyone knows, I wear a Chelsea scarf, which does the same. Sarah, are you with us or not yet? I'm not sure that Sarah is with us, and Hugh has not turned up. So this party is getting smaller and smaller, but still of the highest quality, I'm pleased to say.
Simon, can I come back again on the face mask issue?
You can indeed, please do.
The other issue, of course, is actually if people can wear face masks. Any healthcare worker would say how uncomfortable it is wearing fairly thin surgical masks for any length of period. And we're asking people to wear face coverings, and I had the pleasure of receiving one in the post as a gift from a friend of mine who's a dressmaker, who is actually making them in African print fabrics at the moment. I couldn't wear it for 10 minutes because it was very thick and very uncomfortable. And again, we don't have any formal studies, but anybody walking around now is seeing people wearing face coverings in various stages. I think I've seen more people covering their chins and their beards than actually covering their mouth and noses. So in considering whether face masks are effective or not, we also need to consider if they can actually be worn to have any benefit.
Okay.
And going for your 1 hour allowed exercise outside might not be the time to use a face mask. If you're just going to be maybe in a short period in an enclosed space, maybe, because you're more likely to wear it for a short period. But there's a lot of factors around how people behave that we would need to consider in determining if it is actually worth giving that as advice.
Okay. Now, I've had a smoke screen message telling me that Sarah is with us now, although I can't see her on screen. So Sarah, let's move on then to another topic. And we've been quite a few questions asked about this, and we're going to deal with both on gender issues, ethnicity issues, and COVID. And certainly we've been lax in not covering those, and we'll probably cover them both in their own right shortly. But whilst we're here, though, so Sarah, this issue, what do we know? First of all, just give us the facts as we know them at the moment. I mean, we've seen some very worrying statistics, well, more than worrying statistics about the increased rates of death in BME groups in this country. But would you like to elaborate a little bit about that and then bring in Ebere from the PhD point of view as to why this might be?
Yeah, of course. Hi, Simon. I hope you can hear me now.
I can hear you well.
It's been playing up quite. Yes, okay. So, I mean, I think, and you can see me now as well. Great. So, in terms of the impact this disease is having on people of Black and ethnic minority backgrounds, I think we've seen a disproportionate amount of people, unfortunately, from these backgrounds coming into hospital and with more severe disease. So I think we know, for example, that BMA people make up 14% of the UK population. However, in some areas such as London, that might be up to about 40%. Having said that, I think a lot of the data suggested that despite that, there have been a greater percentage of people from these backgrounds both present to hospital with more severe disease and also ended up in ITU. So I think the data from the ITU study showed it was something like 34% of people. I think Hugh or somebody else can correct me on that if that's not right. And within the area of London that I work, which is an area which is very ethnically diverse, that's definitely been our experience. I mean, unfortunately, we've had a high number of people with the disease and high mortality. So we're seeing a lot of people with comorbidities that we know already put people at higher risk. So hypertension, diabetes, obesity, coronary disease. So we're seeing a lot of kind of these things presenting. But on top of that, I think one of the things that does need more research and something that I think will come to bear from this is the fact that this is actually just highlighting some of the inequalities we have within our society as a whole. So unfortunately, we know that there are social determinants of health inequalities, and I think that's going to be one of the things that will be highlighted by further research in this area.
Okay. And Hugh, I think you've now arrived.
I have.
And what are you seeing in intensive cares at the moment?
Well,
talking about the issue of ethnicity and also gender. Ah, hi there, Hugh. Yeah. Good to see you.
And you, and thanks for having me. So yes, much as you've heard really, there is very much a male predominance here. And it's very clear. Some units, such as ours, it's much nearer 70 to 80% men than it is women. So women do genuinely seem relatively protected from severe disease. And we know from our own data and those from others, this isn't some sort of ascertainment bias, and nor is it some sort of process where, for other reasons, women are being denied access to intensive care or put onto palliative care tracks. It does look genuinely biological. I'd also concur with Sarah's point that we are seeing a surfeit in our areas of Black and ethnic minorities. And I know from other colleagues around the country that they're seeing this in predominantly what are predominantly white areas. They're seeing a very predominantly Black and ethnic minority intake, which is surprising them. I totally agree with Sarah. I don't know whether this is related to social determinants of health, which we do know exactly as she's described. People in these groups often have much poorer housing conditions, much poorer access to healthcare. How much of it can be social and cultural in terms of spread earlier on, and how much of it is genetic, because there may well be that component. But I agree with Sarah, we currently just don't know, and it's a real need for better genetic data, but also better hospital data at granular level for us to understand the drivers of these differences.
And Peter, there was a specific question came in when you were on the show, as it were, asked about ACE receptor genetic differences, which you've already mentioned earlier on just now. Is there any evidence to suggest that that might give one clue to either gender or ethnic differences, or is that purely speculation?
Yeah, I think at the moment we're still looking at all the evidence. In the Ebere 4C study, we had a press conference yesterday at which Callum Semple, I think, made the point very clearly that the risk, the BME, AME excess appeared to be because of risk factors, and particularly because of the occupations that they were involved in, made it very difficult for them to socially distance. They're often on 0-hour contracts and so on, so very much disadvantaged if they tried to exclude themselves. And that once all of that had been corrected for within the study that we've just published, the signal seemed to be to disappear. I mean, in terms of the gender, so it's interesting that the greatest excess of male admissions and deaths appears to be in postmenopausal years. So it's almost as if postmenopausal women are protected against severe disease, which is intriguing. But maybe argue against hormones, being the cause. We don't really know the cause of that yet.
And your study was huge, wasn't it?
Yeah, so it's over 22,000 people. So it's about, I think it's 28% of all cases admitted with COVID in the UK. So that's a huge tribute to all the 2,500 people who've entered data in about nearly 200 hospitals. So thank you if you're one of those people.
Okay, Ebere, can you sum this up for us then?
Okay, so we're looking at both the gender and ethnicity factors.
Yes, and then we'll move to low and middle income countries. But for the moment, let's just stick with the UK, and then we'll go a bit broader.
Right. I still think the jury's out. Like both Hugh and Peter said, we don't yet know everything or enough. to reach any clear conclusions. The evidence suggests that in the UK, there is a definite skew of the gender towards men, both in terms of numbers of cases and severity of presentation. Some of that might be as a consequence of health-seeking behaviour, because it is very well known that men tend to seek healthcare later than women do. That's a possibility. The comorbidities that are clearly associated with poorer outcomes from COVID, there is a preponderance of those in men. Those same two factors in different ways might be part of the contribution to the disproportionate impact on Black and ethnic minority groups. Like Hugh and Peter pointed out, they're overrepresented in the populations that are less likely to be able to apply the social control measures that we're recommending. They are more likely to be in jobs where they are exposed to the public. They will make up a significantly higher proportion of the essential workers who will be expected to continue to be working. There is very clear, and we shouldn't ignore the fact that in every other condition, inbuilt inequalities and biases do affect how people from different subpopulations are treated when they do present to the health service, or in whichever tier. So although a lot of people have said that COVID-19 is the great equalizer, I actually don't agree. COVID-19, like any other disease, will work within the social system that it exists in, and any inbuilt biases and limitations of those health systems and social systems will affect how it impacts on different populations.
Yeah, I think that's fairly. I mean, the story of epidemics is the story of inequalities,
Absolutely.
even more than it's the story of infections. Now then, I stopped counting the number of questions that had come through in the last couple of weeks asking about what is the evidence from low and middle income countries, and a general feeling, and you're now going to tell me if this is correct or not, that things seem to be different, particularly Kenya, Nigeria, etc., with Kenya being the one that was picked out quite a bit, with much lower rates of infection than one might have predicted. Can you fill us in on that? You'll know much more about this.
Well, okay. The first thing, again, seems to be a recurring pattern. We don't actually know for sure, because in a lot of low-middle income countries, the ability to test extensively is limited. The laboratory, and I'd start by stating that a lot of the countries, some of which my project works with, are a lot further along from where they were a few years ago during the West Africa Ebola outbreak, in terms of having systems for responding to public health emergencies. So take Nigeria. Kenya is one of the ones that actually has had a longer term experience of having some very good laboratory diagnostic capacity, for example. Nigeria has come a long way in a very short time. In both those countries, although they are testing a fair number, as a proportion of their populations, they're not testing as many as, say, in most of the Western countries or in countries in Asia have been doing. But the figures,
more like us then.
Yeah, but
more like us.
Like us, I think. But the figures suggest that they are seeing fewer cases than we are. And these are not countries where social distancing is applicable. Like the paper you shared with me, the article you shared with me this morning, which was going on about how do you social distance in a city like Lagos, Nigeria, with a population of 21.5 million in under 2,000 square kilometers, where a third to half of the population rely on a daily wage. So again, the jury is out. Some of the interesting factors that seem to be slightly different and links back to the gender issue, for example, Nigeria is reporting a predominance of cases in women compared to men, which is very different from what's been reported in most of the high-income countries. We don't know whether this is because women are more likely to come forward for testing, again, whether it is partly perhaps affected by the fact that women are more likely to be in caring roles, so the transmission in households might more like disproportionately affect them. We don't know, but the epidemiology in Africa CDC has been doing some really great work in collecting the data across the entire continent. The epidemiology is looking different in some ways from the West, and I think it's going to be one of those ones that people like Peter, their team, and co will need to help us to explain.
Okay, now I'm going to come back to that, but I want to change the subject because I'm aware that Peter has to go. And we do have a little bit more time today, but I do want and I want to come back to a topic that hasn't been asked questions of because it couldn't be, but this was a huge story last night and this morning. The new results on remdesivir and Tony Fauci, normally a rather conservative and met him a couple of times, interesting man, saying that this is a major breakthrough, etc., etc. So I'll kick off with you, Peter, just as I know you have to go. But could you give us an opinion on that, and then I'll bring everyone else in.
Well, I think we're waiting to see the actual data. I mean, what I've seen from this study, it produced a very small shortening of duration of stay, but I mean, that's a relatively subjective outcome. And from what I understand, the primary outcomes in the original trial were not those that were subsequently reported. So it did seem to be a relatively small incremental benefit, and I wouldn't describe it as a breakthrough. So I'm surprised that Tony Fauci did, but I think we need to see the actual data and it needs to be peer reviewed and published.
I suppose if you have to stand next to President Trump for hour after hour, it does cloud your judgment a little. Anyway, but it's unusual, though, to have a data management committee intervene to stop the trial, and that's not common.
Mm. Yeah, well,
okay.
I mean, so there was a vaccine trial, an international vaccine trial, where the data management committee recommended stopping because it achieved a significance. This is in another field, actually. And then they carried on in the North American centers, and actually the significance then disappeared. So need to be a bit cautious over this. Yeah.
Let me pull in the two clinicians. Sarah, are you going to be prescribing this now? Sarah, are you still there? Not sure that Sarah is. Hugh?
No, I'm not. I totally agree with Peter. We need to see the solid data on this, and statistical significance is irrelevant unless it's of clinical significance. So I need to know that it's going to have scale and impact before I change my practice. And I'm going to stick with the practice that the NIHR and people such as Peter have very strongly recommended, which is that we don't start prescribing these things outside of trial criteria until there is very clear evidence. And we're doing exactly that. We're spending a lot of time recruiting patients into the major trials so that we can get very quick answers and solid answers. And again, I echo Peter's view. It's a real credit to the community in the NHS that they have, in a time of crisis, been able to continue to recruit people to studies when it's mostly been sucked back to frontline service.
Yeah, and the RSM series, we constantly are encouraging clinicians to recruit, particularly the 3 major trials and others. And that trial, there is a UK trial in hand, isn't there? Can you briefly mention that?
Well, I don't know. Peter may wish to talk to this. I mean, the major trials that mostly we're dealing with are the ones that Peter's involved in. So Iseric, we're involved in genomic in collecting data. We're involved in the recovery trial. And recovery has been very cleverly designed with an adaptive process, which, for those unfamiliar with it, allows incremental changes in weighting of randomization so that one capitalizes on signal and leads to a much quicker, direct answer. And new treatments are being added to that the whole time. Recovery RS has just appeared, so it's gone beyond drugs and is now including respiratory support. And even those have recruited exceedingly well. I was speaking to the team yesterday. I think they're planning to be up to 36 centres by the end of this week recruiting for those. I forget which limb remdesivir is in, but I do know that in those, the other is Remap Cap.
Okay.
Intensive care end of the recovery. They've again done a great job of making sure these trials interdigitate such that it's not an either or. You can be in one and then flow into the other.
And I'm hoping after this, we will once again remind people of the websites for these trials. We can't emphasize how important that is. Sarah, are you still there? Quite like your view on this?
I am. I'm sorry, I'm on hospital Wi-Fi and it's been very, so I've caught kind of intermittently parts of it. I really apologise.
At least we know you're working,
I think the question was about trials ongoing in hospitals. I think the question was about trials ongoing in hospitals, is that correct?
Well, it was more about remdesivir as to your take on this. I know you've looked at this as well, as I'm sure huge numbers of people already have.
Yeah, so I mean, obviously there was the press announcement yesterday in regards to the big trial from the States. But I mean, I think Peter already has mentioned this. At the same time, there was a Lancet paper which suggested that there was no significant benefit. So I think the jury is still out. The trials definitely are ongoing. My own hospital are actively involved in recovery, as well as also recruiting for remdesivir. So I think it is important that we continue to recruit people for clinical trials and try and collect as much data as possible in order to get a true answer to these questions.
So, I mean, we have a lot of juries out at the moment, I can see that, but eventually, like the juries in the rest of the country, they may be coming back in with some verdicts. Now, whilst you two are there, there were other questions directly on treatment, and let's cover a couple of those now. A lot of questions came in on steroids. So one talks about, should we be using steroids early prior to radiological changes? And another asked a slightly different question on oral steroids. And this is talking about, should we be using them for symptom relief in serious now ARDS patients without asthma? So it's basically about what's the role of steroids, I think. Do you want to kick off, Sarah, and then switch to Hugh and then Ebere?
So yeah, I mean, I think, again, this is another thing that the jury is still out on.
Not that jury.
So we know that the recovery trial does have steroids as one of the arms of the trial. However, I think the initial data in regards to the use of steroids hasn't been very helpful in that it suggests that there is no benefit, which almost in some ways might seem counterintuitive to what we think is going on in regards to the inflammatory response that we see in people later on in the disease. Yeah, I think I'll just wait for there to be further information in regards to study results.
Okay. Yeah, and Hugh, what's your view?
I completely concur. So the early story we had was that steroids might be harmful, that they might worsen the viral illness, but actually equipoise was then achieved because there were signals the opposite way. We're again randomising in the recovery trial, so we've got quite a few patients on steroids as well. I have no idea whether there's any obvious impact. In terms of the downstream impact on ARDS, bearing in mind that the sort of second stage of this ventilated patients is they move from this high compliant pneumolytic process into much more of an ARDS type process. We have to remember that 25 odd years ago, we did used to give people high dose steroids in that fibroproliferative phase. And the UK pretty much moved away from doing that because we didn't really see any evidence of significant benefit in that ARDS process. So out with a trial again, in early phase disease, as has been described, or in late phase disease, I won't be prescribing it routinely, no.
Okay. And Ebere, do you, on these issues, anything you want to say particularly?
No, I defer to my clinical colleagues, they're the experts here.
Okay. Then we also had a question that again, I wasn't aware this was an issue, but it's come up in a few things. This was a suggestion that BCG vaccinations seem to have resulted in lower rates of either infection or severity. Now, I don't know what that's based on, but it was a question that came up in about 3 or 4 of the sessions we had, including yours, Hugh, which I didn't put to any of you. But is there any evidence for this, or is this a straw that we're clutching at? Does anyone know?
No, can you repeat the question there? So in evidence for severity related to, I didn't get the first bit, I dropped out slightly. About
BCG. If you've had BCG vaccination, does that lower your risk or severity of infection? It was a question that was asked more than once, actually, so I suspect it.
I'm not aware of solid data relating to that. Others may. I'm afraid that's off my
no worries. Are you, Ebere? Are you able to?
Again, all I've heard is anecdotes suggesting that there may be some protective effect, but I haven't seen any solid evidence.
Okay. Right, now, then we've got to get...
Peter might have something.
Sorry, it's just still with you. It's rather sort of correlative. So it's an interesting idea that you might get some innate immune stimulation from BCG that might heighten your resistance in general, but I think it needs to be put to a proper trial. It's just by sort of association at the moment rather than direct observational stuff.
Okay.
If we're taking that association to the next stage, then look, going back to the ethnicity data, the Black and ethnic minority populations here are more likely to have had BCG. So we would expect to be seeing some sort of protective effect in that population, which we're not seeing. But again, it is very much a question that we haven't been able to answer. We're not yet able to answer yet. An interesting one.
Okay.
From my reading in regards to BCG, what I found was that there is a few studies that looks at kind of the effect of BCG in, say, young people, children, and the majority of that appears to be an effect in reducing other respiratory tract infections, sepsis, kind of at a young age. They did see this in some people and in some in elderly people who were given the BCG as part of a trial. However, I think overall there doesn't appear to be a lot of
okay, okay, didn't quite hear the end of that, Sarah, but don't worry. Then we'll be able to just do two more topics, I think, and good to still see you here, Peter. Then one thing that we again didn't tackle, but a lot of people have asked, so much so we may have to come back to this as a full session, is still this is the issue of children. Now we're told that children appear to be less affected, less spreading of the disease, less everything basically. Is there anything happened that might change that view? And so really saying, do we still think that? There have been some reports that seem to have scared people a bit and raised concerns. But so firstly, is there anything to change from PHE's perspective, for example, and the clinicians, this view on children? And second, though, about vulnerable children with underlying health conditions. So anyone who would like to come in on that one? Perhaps Ebere, would you like to run the public health perspective?
Yeah, the evidence suggests that children, particularly at the younger age, are less likely to be affected, less likely to have severe infection. And from a public health control point of view, interestingly, very different from influenza, less likely to be transmitters. Yeah. Traditionally, we associate children as vehicles for transmitting respiratory infections. This doesn't seem to be the case here. And that has informed some decisions in some countries to keep younger school age education settings open while closing the other ones. Why is this different? We don't know. That's another list of those things about this SARS-CoV-2 that we need to find out a little bit more about. There are particular issues that have come up, particularly of recent, around particularly vulnerable children, which I will defer to my clinical colleagues to discuss. But at the moment, the evidence does seem consistent in different populations that children seem to be protected and not vehicles for transmission, which from a public health point of view is a very good thing.
Indeed. Now, the specific question was about a 15-year-old who had chronic kidney impairment, and should they be sheltering? I don't know if anyone, Hugh, do you want to give a view on that? One feels the answer is going to be yes, but at least we should check.
Well, I mean, my general feeling for these is that we have to just make sure that we're all being sensible about these things. This is a dangerous disease for a small minority of people. There are people who are slightly more vulnerable. We're not seeing a particular signal in the dialysis community in our region of North London, for sure, but it makes sense. For many of the risk factors that lead to renal disease are often the ones that end up putting you at risk. So it's the diabetes, the hypertension, and others in the elderly, the older groups. In the younger groups, often diabetes too, but also autoimmune disease, and we don't really know how that interplays. So I would certainly be playing safe on that. I would pick up a little on your other point as well about children, because the issue, as you probably were alluding to this week, is the reports of an atypical Kawasaki disease presentation in children, and people suggesting, and a bit of Twitter activity on this, that this was in some way related to COVID. I've spoken with paediatric colleagues about this during the week from different centres, and the feed from them, not from me, is that firstly, these cases are all coronavirus negative, so you can't identify viral RNA in these cases. Many of them have been in households, and there's been a cluster in households where at least one member of that household has suffered from coronavirus, but that's far from saying that coronavirus is in any way causing these diseases. And those I've spoken with are still suggesting that these cases may actually just be late presentations of conditions that would have otherwise presented much earlier before. So I see, talking to those colleagues, they're not pointing a finger directly at coronavirus as being related to this atypical Kawasaki presentation.
Okay. Anyone else want to come in on that? Because it certainly has caused, you know, we already know that a lot of parents are very reluctant to send their children back to school, even when they are open. And I don't think that helped that very much, that particular story. But in general, and Peter, do you want to come in a little bit on you obviously being a respiratory physician, you know about kids?
Yeah, a new study out looking at viral loading in across the age range, showing that when children are infected, actually the viral load is pretty similar to that in adults. But I would say it's very important when we talk about viral load that people don't assume that the amount of virus that you can detect by PCR is equal to the infectivity. So when people refer to viral shedding, it may just be that there's some RNA lying around in cells that even may be pretty senescent. You know, there's the respiratory tract epithelium has a turnover rate which allows persistence of virus even in cells that are relatively degenerate and not really producing live virus. So okay. I think we need to be a bit cautious about that.
And then just a final question, really, we're moving towards the end, and unfortunately we're not moving towards the end of this epidemic, but we are starting to think more about exit strategies. And Ebere, could I bring you in a bit here from the Public Health England point of view? We abandoned contact tracing on the day that my wife got ill. I remember that very well. And now we're talking about that again. How is that going to work now on the scale that we would need it?
Right, Simon, I'll start by a correction. We didn't actually abandon contact tracing entirely. We changed the contact tracing strategy. Contact tracing is bread and butter for any outbreak control, but you have to adapt it to the circumstance that you're in. At the beginning of the outbreak, when the numbers of cases were small, easier to detect and notified early, we were able to actually contact trace all cases, most of them being travel related at the beginning, to identify contacts and isolate them along with the cases. We still continue to do contact tracing now, focusing on controlled environments like care homes, schools, where you can actually, where contact tracing is achievable. But with extensive population transmission and the number of new cases per day, we don't have the physical capacity, or we haven't had the physical capacity to do extensive contact tracing for every single case. So we've prioritized the resource we have to the areas where there's the most risk and most value in contact tracing. What we're now moving towards in the New World Order is the use of new technology to support that contact tracing. So it's not just dependent on what individuals like myself visiting or speaking to cases and trying to identify their contacts. Bearing in mind how challenging that is. At the best of times, people don't tend to remember what they did 2 hours earlier, never mind 7 days before. But hopefully the technology will allow us to actually continue to contact trace, but at a bigger scale. And that should contribute to the plan to step back some of the social distancing or physical distancing measures that we have in place. But we never stop contact tracing. That's one thing that we have continued to do throughout, just different strategies.
I accept the correction, but would you like to say when you think you'll be switching to a different strategy? When do you think you'll be doing this?
I can't say for definite, because that depends on the capacity. My colleagues in the health protection teams and local authorities across the country are still doing contact tracing in specified areas. As more people come on stream, as the technology, the new mobile phone, Bluetooth technology comes to assist us, we will be able to expand that. But I couldn't comment on a date that we're going to say we'll switch from A to B. It will vary from population to population depending on the resources they have, I think.
So the jury then is still out, but you are expanding your workforce.
We are NHS England and PHE in the Department of Health are recruiting both clinical staff and call handling staff to help us do contact tracing more extensively.
Okay. Well, we need to draw this to a close, and there's lots of juries out there, but when they do start returning their verdicts, I'm sure all of you will be back on screen and all across the media as ever, which is excellent. So thanks again to the panel, Sarah, Peter, Ebere and Hugh, and it's very good of you to spare your time. It's really appreciated by the audience and by us at the Royal Society of Medicine. Now, Royal Society of Medicine Live, we take the weekend off now, but we will be returning on Tuesday with a somewhat different program. Dr. Claire Gerarda will be our guest to talk about mental health issues and health professionals. She set up and led the Practitioners Health Program, one of the world's authority on sick doctors. So we'll be talking about resilience, illness, and so on. Now then, I'm not going to emulate the show Mr. and Mrs. For those who knows, you'll know why that is. So we're going to need another person in the chair, and I'm very delighted that will be Dr. Adam Kay, former junior doctor and of course best-selling author of Your Life in Their Hands, our most successful author since Charles Dickens. So if that doesn't make you tune in, nothing will. So it'll be the Sarah and Adam show. God only knows what will happen, but it won't be dull. So until then, as ever, thank you very much. Remember the RSM, who's running these shows, and very much please stay safe out there. Thank you very much. Good afternoon.